So I have the second talk, which is the filter complications. Perfect. So, sorry, I'm going to take this off. So I'm going to give a quick talk. It's a little bit backwards. I think it would have made more sense for Aaron to give his talk first, but I got to run down to help Dr. Lichtenstein with his live case. So, I'm going to talk about the immediate and long-term complications of inferior or IVC filters here. So IVC filter placement is a relatively low-risk procedure. I think filter usage really peaked around 2009, and then with a rapid drop-off by 2012. I think everyone sort of realized, and I think if you watch enough TV, you've probably seen the commercials, that we're probably placing too many filters, not doing an appropriate follow-up. And so I think a lot of the drop-off is from that. Also, the reimbursements changed, so that kind of helped with that as well. If you look at the data now, most filters placed in the U.S., vast majority, probably about 3/4, maybe even more, are actually retrievable filters, but not a lot of them are coming out. Just for the trainees and people who haven't seen it, but this is actually the original filter designed back in 1968, I think, called the Mobin-Uden umbrella filter. You probably will never see one of these, but just for historic purposes. So if you look at the complications immediately, there is reported complications of vascular access and placement of filters, somewhat similar to the placement of central venous catheters. Most common is bleeding at the access site or access site thrombosis. If you look at the rates are actually quite variable for access site thrombosis, mainly really due to most of them are asymptomatic, and so there's variable follow-up or no follow-up whatsoever. So the actual number is not really clear, but it's probably still pretty low. And if you look at the other complications, filter tilt, this can occur over time or actually during immediate placement, and that's defined as tilt greater than 15 degrees. And this can be seen with all filters except for the bird's nest filter, which I think Dr. Fishman's going to show you a picture of later, but just by virtue of the way it's placed, it just really can't tilt. There is no reported rate of increased thrombosis with tilt, depending on how far tilted it is, but there is some questionable effectiveness in preventing PEs. In reality, I think now, given the fact that most filters are retrieved, if this happens actually at the time of placement, I think a lot of us would actually retrieve these and put them in straight, knowing that it can become more difficult to take these out later when they are tilted. Filter migration, this can occur again during or after placement, and it's defined as greater than 2 centimeters of craniocaudal movement from initial placement. It can be related to undersized for the IVC. Most of the filters currently available on the market have an IFU of about 28 millimeters. I think some of us are willing to push that a little bit, but not much more beyond that. So if you undersize it, it will fly on you. Actually, I think what is a lot more common than we would like to admit is actually during central venous catheter placement. That J-wire gets hooked on the filter and it gets pulled back up, and this is actually what happened in this case here, and the filter just sort of gets mangled, or if you're more unfortunate, gets tossed to the heart. Migration rates are low if you look at overall, sort of long-time migration rates, basically as low as less than 1%. The G2 filter, which was about 4.5%, 5%, actually no longer on the market, and most of those actually occurred about 30 days after placement. Here's a case of one of ours, which was actually migrated to the heart, which we were able to luckily get out. But some of these patients, we can't get them out even from the heart or the lungs, and we have to send them on to surgery. So there's incomplete opening of the filter, which can happen. Sometimes can be related to a defect in the filter, which I've actually not seen. Most of the times, it's usually related to unidentified thrombus in the filter, in the cava, or more likely actually just malpositioned, usually in the gonadal vein, which is actually what happened in this case. It doesn't project very well, but you can see the filters partially in the gonadal vein squeezed down, and then the rest of it's kind of sticking out here in the IVC. So if that sort of segues well into non-target placement, the preferred placement is the feet below the renal veins and the cone above the confluence of the renal veins, the apex, in the renal vein outflow. Most common malposition is actually in the iliac vein or too high in the suprarenal IVC, but we've seen, as I showed you there, the gonadal vein, renal vein, aorta, and even into the spinal column. Here's a case actually on the right. You can see here, this is actually when they went to go and take it out. Here's the wire down, but the filter's actually a little bit too far to the right, so this filter's actually in the aorta. And this is a filter, it's a gentleman actually we just took out last week. I'm gonna pause this here. And you can see here that here's a greenfield in the right renal vein and one in the IVC. This was placed about 30 years ago. He was told that they had a device malfunction. Clearly they just put it in the wrong spot. Luckily, we were able to get this out. We did a discussion about actually taking this out, but he actually had severe symptoms. He lost about 40 pounds of weight, just trying to lose some weight, and then actually, as he lost his weight, he started to have pain from this filter because it started perforating into, out of the renal vein. Here's that case of into the spinal column. This is actually placed from the groin. You can see here there's extravasation, and here's the filter, and they got a CAT scan. Probably what happened is when they went up with the wire and the sheath, delivery sheath, they weren't actually in the IVC. They were in some sort of collateral spinal vein. It's actually in the spinal column. Apparently the patient had no symptoms from this, which I'm shocked, but apparently did okay. So IVC filter clot and caval thrombosis. Rates typically about less than 10%, but vary from 2 to 30%. Trapeze apparently has the highest rate, about as high as 25%. Most IVC filter clot in the filter is asymptomatic, as opposed to caval thrombosis. And here's a patient who had clot in their filter, but this is actually asymptomatic. Thrombosis may be increased risk. Thrombus in the filter may lead to increased risk of PE, as the clot can extend above the filter. Here's a patient, a 63-year-old woman with an IVC filter placed in an outside institution 3 years ago, DVT and PE as she was pending spine surgery. Basically comes back, filter was never taken out, or actually she didn't actually have a retrievable filter placed. 3-week history of acute onset pelvic, bilateral extremity swelling and pain, not improving with anticoagulation therapy. Here's just sort of the drawing of the filter, of the duplex map, basically extensive bilateral DVT, an NMRV showing again DVT up extending into the filter. Oop, that went way too far back. Sorry. Sorry. So here's the venogram showing extensive clot. We placed ECOS catheters. You can tell exactly how old this case is because we still used urokinase at the time. We could get it. So we placed bilateral ECOS catheters. We were able to infuse. We got rid of some of the clot. Some of it was already chronic at this point. Cleared up. We decided at this point just to stent through the filter and use some Teratola and some mechanical thrombectomy to get rid of the rest of the clot, and she did actually pretty well. Filter fracture is basically related to structural failure of the filter itself. It can lead to fracture and potentially embolization. The incidence is low, about 1 to 2%. Less common in permanent filters. Fragment embolization, you can see it in the renal veins, pulmonary circulation, heart, hepatic veins. Here's one filter that's fractured here. Here's one with a leg that's up into the pulmonary artery. Here's one that's actually embolized somehow into the hepatic vein. And here's one where they actually were able to get out the tine from the pulmonary artery. Perforation and penetration defined when the filter is out greater than 3 millimeters. The IVC is not a fixed structure. It actually moves. It sort of has this sort of compressive movement to it with aortic pulsations and respirations. As the hooks have been added to the filters, that's lead to decreased migration but increased risk of perforation. Retrievable filters have found to have a higher rate of perforation than permanent filters because most of them have hooks. In fact, you look at the MAUD database, which is run by the FDA, 20% of the complications of the complications in the MAUD database related to filters are actually related to perforation. And here's a case actually of perforation into the aorta. This is actually from a lawyer's website of a filter leg through and through the duodenum. This is a case actually from one of our surgeons, Dr. Hahn. This is a bird's nest filter that was placed a while ago, and you can see it actually perforated into the aorta, causing a pseudoaneurysm of the aorta, which he actually repaired the pseudoaneurysm, but we ended up leaving the filter. This woman was the most healthiest individual. Here's another filter that's perforated. We were actually able to get it out. Some of it got stuck. We actually got it out in pieces. You can see the pieces that came out here. And then here's another filter, just a couple other examples of filter perforation. Here's one that's perforated into the renal vein and into looks like into the proximal small bowel. And again, we were able to ultimately take this out just using the forceps, which actually Dr. Fishman kind of showed you how to do earlier. So in conclusion, with the advancements in filter design and the incidence of complications has decreased, although they have actually changed the types of complications we see. I'll be honest, the true complication rates are probably really not known. Many are asymptomatic, and most of these patients have little to no follow-up. Due to that, and actually sort of prompted by the FDA, the SIR and SVS are currently enrolling patients in what's called a PRESERVE trial to look at the safety and effectiveness of IVC filters. It's a massive multi-center registry across the country. And ultimately, in patients, I think the easiest thing to remember is in patients who don't need the filter, we really should be getting them out. Thank you very much.